So patient named Mr. RK, he's a 62-year-old male. He's a retired school teacher by profession. He presents to us with complaints of reduced urine output, that is for 2 days, generalized weakness, fatigue, and swelling of the feet since 1 day. So all three are the important, chief complaints that the patient must look into it. So history of present illness, patient was apparently well until 4 days ago. What happened? The patient develops acute gastroenteritis with multiple episodes of vomiting and watery diarrhea. So then the patient noticed there is progressive reduction in the urine output. And how much this reduction was there? Less than 300 ml per day. The patient also complained of what? The patient complains of dizziness. The patient complains of fatigue, muscle cramps. Negative history, there was no history of any fever, rash, hematuria, dysuria. So any, acute, any secondary infection, any autoimmune disease, any, muscle breakdown, rhabdomyolysis, dysuria, flank pain was not there. There was even no recent trauma or surgery history. Past history, the patient is on ACE inhibitor since past 10 years. Occasional use of NSAIDs for knee pain. No known chronic kidney disease, no diabetes. Very important. Drug history, enalapride, NSAIDs intermittently. Family history, no known history. Pulse is a bit on the higher side, tachycardia, 110 m per minute. BP is 90/60, lower side, orthostatic hypotension. Respiratory rate on the higher side, 20 ml, and the patient is afebrile. Signs of volume depletion, dry oral mucosa, jugular venous pulse not visible, reduced axillary sweating, and poor skin turgor. So if you are pinching the skin, that is taking time to go back to its normal position. So when we did the systemic examination of this patient, the cardiovascular revealed tachycardia, respiratory system was normal, abdominal and genitourinary was also normal. So provisional diagnosis of acute kidney injury due to pre-renal cause due to volume depletion was made. So based on the history and examination, hypovolemia due to GI loss, intrinsic AKI to be ruled out, post-renal cause unlikely. So we ran a couple of battery of investigations and creatinine was on the higher side, 3.2. Urea was also on the higher side, so ratio will be definitely on the higher side, greater than 20:1. Sodium slightly less, 132, potassium slightly high, 5.6, and ABG suggested mild metabolic acidosis. Urine examination, urine sodium was low, fractional excretion of sodium was less than 1, and urine sediments had showed known cast. Ultrasound abdomen, normal kidneys, no hydronephrosis, so a final diagnosis of pre-renal acute kidney injury due to hypovolemia following acute gastroenteritis was being made. So what was the immediate measures? Discontinuing of the ACE inhibitors, NSAIDs was being done. Inserting a urinary catheter, why? To monitor the input-output chatting. We put the patient on isotonic saline 0.9% NaCl. So we gave 500 ml over 1 hour fluid challenge test, and we monitored the BP, urine output, jugular venous pressure, and lung auscultation. Strict input-output charting, weight monitoring of the patient, monitoring of the serum creatinine electrolytes. Along with this, monitoring of this fluid overload was being done. As the patient developed mild hyperkalemia, we restricted the potassium diet, and metabolic acidosis was being managed conservatively. So after the fluid resuscitation, the PP of the patient improved, urinary output improved, and creatinine started to decrease. So what was the outcome? Final outcome, renal function improved. There was no requirement of this dialysis, and patient was discharged very well with advice of hydration and avoidance of this nephrotoxic drugs like NSAIDs and even ACE inhibitors, which was being there. So there was no requirement of this dialysis, which was being there.